Thank you, thank you. Okay, so it's nice to get to see some of my professors again and some of the people that I've worked with before. And of course, Midge, she helped me with a lot of this project, or did most of the project, like as far as the other side of it at the hospital. So I'll go ahead and get started. Like you said, my name is Brandy Pitts, and I just finished my DMP. This is just my DMP project that I'll be talking to you today, and it's called Using a Sense of Urgency to Implement an Adult ECMO Program During a Global Pandemic. So some of you may know what ECMO is and some may not. So it's a rescue therapy for severe respiratory failure or cardiogenic shock. The indications for adult use have increased, and clinical outcomes vary depending on the infrastructure of the organization. ELSO is the international organization that provides guidelines for ECMO centers. It identifies members of an ideal interdisciplinary team, and it's a registry to track your outcomes. So the problem, putting a project together, you need to identify a problem. The problem was we didn't have an adult ECMO program. We had a pediatric program established for a while, and we would occasionally put an adult on ECMO using, our knowledge from our pediatric program. But we didn't have all the other things in place. As you can see here, no interdisciplinary team, there wasn't the collaboration, no specific guidelines for adults, the inclusion and exclusion criteria was not there, and we did not have an adult ECMO director. So how many of you have tried to implement change in your organization or been part of a change that wasn't sustained? Yeah. Okay, so most of it. Usually that's because of the implementation of the plan, the program, or the lack of plan, right? And so to maintain sustainability and have a successful implementation, I use Cotter's 8-step leading change model. And so for the first step, that's create a sense of urgency that you can see here on the slide. So in the midst of getting approval for my project, COVID hit. And so that created a sense of urgency, right? Because we knew that there was going to be an increased need for adult ECMO for COVID patients. So while we were getting it approved March 2020, of course, it kind of expedited. It got approved quickly. And World Health Organization guidelines came out the 2020 saying that COVID was, ECMO was approved for COVID patients that were not improving with conventional therapy. Okay, so the purpose was to implement or to lead an interprofessional team in establishing an adult program utilizing evidence-based practice at a large West Texas hospital. It's like a secret or something, right? Okay, so of course, where do you go first? Go to the literature, kind of find out what's out there. We want to make sure we're doing best practice. So I found the ELSO guidelines. This outlines the institutional requirements, roles and responsibilities. You need a physician to be your ECMO director, and it outlines everything, very specific. And then policies and procedures. And that's, of course, for your management, termination of ECMO, inclusion, exclusion criteria. And then there's 4 factors that are essential for a successful program. And that's at least one ECMO physician, designation and training of ECMO specialists, early identification of patient selection criteria, and continuous training for programs with low volumes. Implementing an interdisciplinary team, this is the things that are the positives. So you'll have improved clinical outcomes, decreased in-hospital and ICU mortality rates, increased successful weaning off ECMO, increased survival rates, improved communication and collaboration, and decreased 1-year mortality rates. So who wouldn't want to do that, right? Ethical considerations, so if you're thinking to yourself, do I want to implement an ECMO program? Things that you should consider are, usually ECMO is, like when you put somebody on ECMO, it's not something that you've sat down and had a lot of time to think about with the family. And so there's a lack of not a lack, but not enough communication. And sometimes the family, people don't understand all that's going on. And so there's unclear perceptions of goals, treatment limitations, there's futility. You have patients that are with it, their bodies just can no longer, function. So we talk about withdrawal of care. So how do we address these things? There's the ECMO-specific consent form, and that's how we address it with evidence-based consent form. Did not require IRB or approval or anything. Of course, we got approval from the site and from my counsel. So the design was program implementation. The framework, I used a logic model, and many of you probably used a logic model before, but it helped in assisting with the designing, the planning, strategy development, monitoring, and the evaluation of the program. And so it's like a visual roadmap, so it kind of helps you, and I'll show you what mine look like. But these are the elements of a logic model. So I don't know if you can read it or not, but when you do a logic model, you always want to start with the outcomes, because knowing where you're going, you can choose the best path. So we started here. Of course, my long-term goals would be to receive the Platinum ELSA Award, because I'm always going big, right? Yep, that's how I like to do it. But, so we back up to our intermediate and our short-term goals. Something short-term is like improve the collaboration and satisfaction among the team. We want to make sure that they feel comfortable taking care of the patients. Are we making good decisions? Are we putting the right patients on? We want to standardize their care, and then identify measurable clinical outcomes. And then, so our outputs are activities and participation, and then we have our inputs. So this was my logic model. Methods, so we go back to that Cotter's 8-step model and build a guiding coalition. So we assembled our group. That's step 2. We did a SWOT analysis. And then we go to step 5 is enable action, remove obstacles. So this was the implementation phase. And that's where we established our policies and procedures, did ECMO specialists and bedside nurses. We did the training. And then ELSO quality reporting system was set up. Here's just like a glimpse. Again, it's pretty small. But on the right-hand side, left-hand side, is the table of contents of the resource manual. It has all the things from how to set up things, where to find things. And then the other is the ECMO specialist training. So it's a 5-week program. It's just 1 day a week, but 5 weeks where specialists were trained on how to be an ECMO specialist. So the evaluation plan, this is step 6 of the Cotter's model, and generate short-term wins. So when you go back and talk about those short-term outcomes and the goals, you always want to celebrate, because we need something to celebrate, especially right now, right? So if we're getting things done, if we establish our goals, let's celebrate it, and then we can move on to the next step, keep our team energized. So development, standardize patient care protocols. So that was with the policies and procedures. And then develop measurable clinical outcomes. And this is what we are tracking: survival off ECMO, survival to discharge, major and minor complications. And then this CSACD tool measures collaboration and satisfaction. So we wanted to know, so before program, I sent out a survey, and it's a validated and reliable tool. And I got permission from Dr. Judith Baggs to revise it and distribute. But so we use this tool, send it out, ask the questions, and I'll give you a couple examples of the questions in a second. How do you feel about these things? Strongly disagree to strongly agree. And then, of course, we did it 6 months later after the program implementation. So we wanted to know, how do you feel about the decisions made within the team? So here are the results. You can see the pre-intervention and post-intervention, the participation, and then the collaboration and satisfaction scores. Here they're presented in the mean, but we actually did it we measured it with the medians because the data violated the assumption of normality. So we did the non-parametric Mann-Whitney U test. Let's see, so out of curiosity, we ran the independent samples t-test and the conclusion was the same, no statistical significance, even though it was significant for us. And then for our project, the tool had a high level of internal consistency as determined by Cronbach alpha at 0.950, and this provided further reliability, evidence of reliability. So even though it wasn't statistically significant, we did see improvements. Our collaboration, we saw an increase in the minimum score, and for satisfaction, we saw an increase in the maximum score. And so for individual questions, like we saw open communication among team members takes place in decision to place an adult on ECMO. So that's the question. And we saw an increase from 68.9 to 79.1. So that's an increase of 10.2% in that 6-month period. We also had a 6.2 decrease in the strongly disagree category. And then how satisfied are you with decisions made for adult ECMO patients? We saw a 10.8 increase in the strongly agree category. So COVID-19, while we're doing our project, it was in the midst of COVID-19. So many projects had trouble, getting to the end, or they had to revise their project to be able to get through. But COVID provided us that sense of urgency. So the timing was good for us, not so good for others. It, like I said, created that urgency. It increased the number of ECMO patients so we could test the things that we were doing. And it allowed us to do that rapid deployment. The bad was staffing and schedules. So staffing in the hospitals right now, as you know, very busy. And then you try to train an additional, the first set of technicians we tried was 17 and then an additional 15. So trying to get them out of their own staffing to be trained for specialists can be challenging. And then of course the ugly was COVID. So limitations, the time frame was only 6 months between the program implementation. So the pre and the post survey, there wasn't really enough time to make sure that all the things are in place, enough patients to test. So there was only 2 patients during that time, and then the number of responses. So not everybody that completed the first survey completed the second survey. And as a novice doing this type of stuff, I didn't match them. So that changed what all I could do. I couldn't run any paired sample tests. So lesson learned. And then, just quick turnaround from training and then having to be able to sit pump quickly. Recommendations, I think we often don't use urgency as like our friend. We should use that more often to get things done. Use it for your advantage. Take advantage of it. And then build a team. Of course, Midge, Dr. Shannon, all of them, they're the ones that put it all together and made sure that everything's running, that this all happened. Utilize guidelines, evidence-based practice. I keep preaching to the wrong group. You all know exactly how important evidence-based practice is and how it improves patient outcomes. Set goals, set realistic goals, and celebrate the wins. So important. And then embed in the culture. So create long-term commitment and sustain best practices. So in conclusions, implementing an adult ECMO program is a journey, not a race, even though it felt like a race. Quick turnaround. Take time to establish your procedures, train competent specialists, and measure meaningful outcomes. COVID-19 provided that unusual opportunity for us to do this and provide the highest level of care in a very short amount of time. And the short-term outcomes have been met. We're committed to meeting the intermediate and long-term outcomes to keep our patients safe and our staff satisfied. And so here was Dr. Acton was my advisor. Kyle Johnson, Dr. Johnson helped with the statistical analysis. Of course, Midge Vaughn was the expert in the our ECMO program director, and my family. And so be the change. That's like the whole way through school. That was always anything I had was be the change. So that's why I have that little bracelet. It's my bracelet I wear every day. It's up there. So questions?
You said there were 2 patients in that 6 months. When did that end? Like, have you seen more? Is it something that they've been using?
Yeah, so Midge can speak to it more. We've had 10, they had 10 patients in the last year, in just 2021. And so that's a lot of patients for us. Even with pediatrics, we didn't do 10 patients a year. So 9 of those, no, 11
We had 11 total. 9 of those were
COVID patients.
Of those 9, 8 of those were COVID. One of our peds was a 16-year-old that because we had, my son had COVID, so I'm just trying to be really careful for y'all. We actually had a 16-year-old who was not doing well, but we already had an adult on ECMO at CMC, and our team is not big enough to have someone on at CMC and then another on at Children's. So we actually transferred her because she was 16 and over 100 kilos, so she was, even though she's not an adult, we all know that, but she was an older teenager, so we felt comfortable bringing her over to SI. And then we cannulated her the next morning and were able to transfer her to Cook so that she would get, pediatric specific care afterwards. But we were able to get her cannulated until, she could get to Cook. So anyway, so we had a total of 11 non-adults. 8 of those 9 were ECMO, ARDS, and all but one of those survived the discharge. I've been actually calling and talking to some of them, getting updates on what's going on with them. At the adult hospital, our practice has been to get them cannulated, get them stabilized, and send them out to a bigger center. And I hated that. It just frightfully irritated me. But
That's on the intermediate goals to keep 100% patients.
yes. And so, but what it did do during this pandemic is allowed us to help the next person. We have 3 cardio help pumps, so we can only have 2 people on at a time. So if we send one out, then that frees up that pump for the next person. Because these are usually long runs, like several weeks. But because everybody was so busy, it wasn't always immediate. So we would have maybe somebody for 2 weeks and then send them, or 3 weeks and then send them. And then we got to a point where everyone was so full we couldn't send them. And so we actually kept our first adult, Leo Silva, to the, cannulated, took care of him through the entire process. He cannulated him and he went home. I actually talked to him this week, and he's back at his full-time job. Doesn't say he's doing great. Anyway, so it's a mixture of whether they stayed or not. And but they've always done so well. One of them did have a small stroke when they were at Medical City in Dallas, and so that'll be something that will, affect him for the rest of his life. But it's just been amazing the outcomes that we've had this year. To put 11 people on, kids and adults, and only have one not survive ECMO was just really amazing. And the team, basically from August to almost December 1st, we had someone on. And we just learned so much, just the repetition. We can cannulate someone like that now. If we could really get the support and backing from administration, because ECMO is expensive, and that's the kicker with it. And it utilizes a lot of resources, so it's one of those. But anyway, it was just really awesome, and just trying to. We've done ECMO with children for a long time, but since we don't do the congenital heart surgery anymore, that's decreased a lot. So doing this collaboration and trying to translate that over to the adult world and make it right for the adults and keep get going for the kids, and it's really been great. And this year was awesome. I'd be interested to see that survey now.
Yeah, and then that's what we need to do is just read.
We had put like 2 on, and we were in 2020, the outcomes weren't great. 2021, they were awesome. So, but having a good period of time of having a lot of patients and the ECMO specialists getting a lot of experience would be interesting.
Well, there's probably more buy-in now that some more will participate. I mean, hopefully we'd see an increase in response rates just because you have, I mean, you went from people, the pre-survey, like, well, I haven't even had an ECMO patient in a year. What do you mean? So I don't remember our communication last time. And then post, I've had 2 patients and it's been hectic. Y'all are implementing this during COVID, you know, and then to see maybe after a year of having patients, having good outcomes, what that would look like.
You gotta do everything in that time frame.
Right, yes, our time frame is very short.
Where your specialists have, because agency loans are really going to be a lot of people. So what are you doing to maintain competency and getting people trained?
So that's,
More classes.
Brandy and I were just talking about that actually. That first class we did, Brandy was really helpful with it. We trained 17 and I think
I mean, we weren't even a month out of the training. Yeah. And then, but then, yeah, it's traveling, they're young and excited and heck, if I could go make $5,000 a week, I would do it too. I mean, I don't blame them, but it was tough and a little frustrating, I can admit. And then the second class we did, we had people on ECMO, multiple. We actually had 3 on at one time because we had a little timing situation where we had an extra pump in-house, so we had 4 pumps at once. Anyway, just kind of lucked out. But, and then I'm trying to do this class in the middle of it, so my perfusion team really helped me to allow me to go teach the class when I'm supposed to be over with it, you know. But anyway, so you know, we do monthly education and quarterly wet labs, and I'm trying to implement, like I said, it's an expensive therapy, right? It's a lot of resources. The perfusion team, I couldn't do this without them, but when they have to be at the hospital for the ECMO patient, they're very expensive. So I'm trying to get about 5 assistant ECMO coordinators trained, which is, the training is expensive, but a couple of ECMO shifts by a perfusionist is going to pay for that. But there's not a lot of forward vision is sometimes hard for people to see, especially in the middle of a pandemic. We want to put $30,000 right now for that. Well, it's going to save $300,000 later when you have to pay those perfusionists. But getting some ECMO assistant coordinators trained so we can decrease the utilization of the perfusion team will help us a lot. So giving people goals of levels on the ECMO team, like it's not just an ECMO specialist and that's it. There's some senior specialists and then these assistant coordinators. So that's something I think that's really encouraging, and we're implementing things they use the ECMO team as part of the point system for your RN3 and your RN4. So.
I've got a question for, working in critical care, so talk to me, for those of us that aren't in that really acute area now, so are there clinical practice guidelines that guide who's a candidate for this? How's that decision?
So that's the inclusion and exclusion criteria. So, you know, certain age, weight, I mean, there's a lot of criteria to match. You know, you can't be on 100% oxygen for too many days, you know, so there.
Adults as well, so for
Yes.
both.
It just means that.
Yeah, like for adults, also the kind of governing body of ECMO, they put out guidelines. And then of course during the pandemic, those guidelines were kind of squished down. Age is lowered, and then it was all about BMI, like the BMI had to be less than 35. Well, then they decided, well, there's these really young people, but their BMIs are higher, so are we saying they're not a candidate? So then it was their BMI plus their age. If it was less than 75, then they were a candidate. So ECMO is a very gray world, but there are definitely guidelines and inclusion and exclusion criteria. things that would exclude you. Whatever is going on has to be a reversible disease process. We're not gonna, ECMO is a bridge to something, whether that be recovery, a long-term device like an LVAD, or eventually maybe a heart transplant or lung transplant, something like that. Or a bridge to a decision that you don't really know what's going on yet, but it's, whatever's going on has to be something that can improve. You're just giving them time to get over it, and you're supporting them in the meantime. So, you know, devastating neurologic issues, or like with babies, sometimes their pulmonary pressures are just too high, and that's not going to change. We can keep them on ECMO forever, but if your pulmonary pressures are too high, nothing we can do about that. You can't change someone's terminal cancer, that kind of thing. So ARDS, sepsis, cardiogenic shock, those things that you just need to support them while they can heal and get over it. That's the ideal situation.
And you have patients, and I'm sorry if I missed this, that had COVID that were also on ECMO. That was a COVID.
Yeah, so 9 of our 11 patients were all COVID ARDS.
I'm sorry. I missed
So that's
that.
okay. In the previous year, in 2020, you know, the patients were older that were getting so sick. And so I think we were using 60 or 65 as the age cutoff. So the patients were older. But some of them are still in their 40s, usually, you know, their BMIs were pretty high. But you know, I don't really know exactly what the difference is, but I can say the oldest one who's been on this year was 47, and he did great. And so, I think this year they were just younger.
Do you think the implementation of this progress will improve your outcomes, even though the surveys didn't really show that, but from your perspective? since
I
you
do,
did
just
it-
having that collaboration, and I think Brandy would agree with this. In the past, we just would throw an adult on because they were dying. And in the past, ECMO was seen as the last-ditch effort, and that's really archaic thinking. It's standard of care now. It's on the sepsis algorithm. It's on ARDS treatment algorithms. And so in the past, there was no captain of the ship in the adult world. Dr. Carroll, who was our pediatric cardiac surgeon, would, you know, get involved and help get them on and all of that, but there was never a captain of the ship. And so now we've got Dr. Jack Shannon, who is just a wonderful person outright, who's the captain of the ship. And then we've got 2 other guys within our like the lead charge for adult ECMO, and that makes all the difference in the world. Because they're seeking out what's best for these patients, and they're talking to other physicians at big facilities, and that's the beauty of ECMO. It's not a secret. I can call anybody in the world and ask them questions or gain insight or wisdom, or you know, just from their experiences, and everyone's willing to talk about it.
It's because like CRTs, you tell, like, they wait till like the last ditch effort, not as proactive, but like the program is really proactive. I can see that.
Yeah, because like CRT's been one of our big, because right now, the whole staffing shortage, and should we create this one-on-one situation, and you know, one nurse to this one patient kind of thing, and Dr. Shannon's argument's been, you'll put a balloon pump in an 80-year-old guy, you'll put an Impella in an 80-year-old guy, and you'll put an 80-year-old guy on CRT, creating a one-on-one situation. So why aren't you willing to do this for this 33-year-old father of 5? So it's kind of a thing.
It is.
Brandy, I think this is a great project. Like you say, it was, you know, it just had to happen. I mean, and it was fortunate that you were there and had a passion for it, and it could help you move forward.
Thank you.
To me, it's a great example of what we want DNPs to be doing in practice. It's research utilization, and we had the evidence for pediatrics, but we needed more for adult. And so you really pushed that evidence into treatment of adults. And what amazing timing with the COVID, hitting at this specific time for you to be studying this and utilizing this treatment in this type of patient. So I think, a lot of times we think of the PhD as the nurse scientist that generates more knowledge, and what we really need from DNPs is utilization of the research and getting it into practice. And I feel like that your project has done that just wonderful. It just sounds so exciting. I love hearing you talk, Mitch, about it.
That's been great. Brandy, also, Dr. Pitt, excuse me. Do you have any perspectives or shared wisdom? One of the things that strikes me is so often as nurses, we don't value ourselves as a knowledge worker as really as we should. And I just think about the cumulative knowledge you had as a nurse of the roles that other people could play, and the interprofessional team, and how that is much like VAP and so forth, that it's the interprofessional aspect and having everybody thinking, playing from the same playbook that has really improved the outcomes. Can you speak to that and what that was like for you as a DNP to lead that?
Well, absolutely. I remember going back to Dr. Harrell. He kind of is the one that started having interdisciplinary team with just our heart patients. So at first we would only have, meeting. He would get everybody together and we're going around at this time, and it kind of was like eye-opening, oh, this works really well because everybody knows what the patient's on, what's happening. I was like, wow, great idea. So, seeing that come full circle to, the ECMO team and seeing, you see it in all the other patients, how important it is. Well, why not your sickest patient, the highest level of care patient in the hospital? Why would we not have an interdisciplinary team where everybody is talking together, making decisions together, instead of, I'll put him on, I'll run the vent, I'll do the medication. I mean, it just works so much better. And I think you can see from the outcomes of, going from no survival, very little survival to, 10 out of 11 survived. I think it makes a big difference. I also think we're putting them on earlier. There's a lot of things that are making the difference, but I just think it's crucial. You just cannot do it without it. I mean, the evidence is there in the literature, and the evidence is.
And the multidisciplinary aspect was a huge step forward in the program. In fact, these patients, we've gotten physical therapy involved early, and we actually got our last patient up and shuffling, and he didn't walk per se, but standing up, using the walker, turning and helping sit down in the chair, which is a big task, and we had all that going on.
Something that we never thought. We hear of these programs that would walk their patients, and we're like, what? There's no way. You can't actually do that. And, it's just, when you have everybody, you have the right people on your team, you can do that, but it's working together and it's, very logical. Okay, I'm going to do this, you're going to do, everything is just working together. It's really nice to see all the teams. And then you have so much respect for each other and what, the other disciplines are doing and their role. I think it really helps with communication, collaboration, all of those things. Yeah. Oh, he's in sim.
Okay.
Well, thank you.
Anybody in the audience, because hopefully this inspires a lot of us to see what's happening.
Well, thanks for listening. Coming on this whole day.